morning, dear friends. My name is Dr. B.I. Patel. Today we will be going to discuss regarding the early pregnancy. Early pregnancy seems to be a very small subject in the past. Now with the introduction of the transvaginal sonography, it has explored many problems of the early pregnancy. And because of the transvaginal sonography introductions, we will be reaching to the target organ which is there in the uterus with the help of the vaginal aperture. And the transvaginal sonography is a high resolution probe. And so people are saying that embryology should be rewritten with the help of the transvaginal sonography. So you will appreciate over here the implantation, the gestational sac, the fetal pole, the crown rump length, how to measure the fetal embryo, then criteria for the viability and amniotic cavity. There are many subjects regarding these all things. Today we will stick to few of the specific problems, physiological problems regarding that one. Regarding clarification regarding the menstrual age and the gestational age. There is, with the help of the assessment of the transvaginal sonography, there is no much difference in this definition. And because of that thing, menstrual age is considered to be the same as a gestational age. Earliest structures of the pregnancy we can appreciate with the help of the transvaginal sonography is a gestational sac. Transvaginal sonography, you will be able to appreciate these hypoechoic structures in the middle of the cavity of the uterus. It is a echogenic rim around 2 mm, smooth contour, no angular border. Then chorionic thickness will be more than 2 mm. We have to assess the mean sac diameter that will be usually growing at a rate of 1.13 mm per day. Inner to inner we have to assess, we have not to measure the boundary. Then intradecidual sac sign and the double decidual sac sign we will be able to appreciate very nicely. In coming few of the slides we will be appreciating that also. Then pseudosac also we have to have a differentiation from this part. It can be used for dating but not accurate, and because of that thing later on after embryo appears we will be able to measure the embryo with the help of a crown rump length, and we will be appreciating the gestational age. So the sonographic assessment of embryonic period, identify the normal embryonic structures assessment sonographically, then understand the sonographic features of the abnormal early pregnancy. These all features we will be able to assess. So the guideline given by many international and national bodies, and because of that thing we have to follow that guideline. So the normograms for both CRL and mean sac is available. You have to follow that one. In presence of the embryo, CRL provide a more accurate estimation in comparison to the gestational age. Because of the mean sac diameter value shows a greater variability of gestational age prediction. Assessment of viability, usually when embryo reaches to more than 4 mm, we will be able to see the cardiac activity. Until 53 days, 12 mm embryo distinguishable by cephalic and caudal assessment with the help of sonography. So the terms viability implies the ability to live independently outside the uterus, strictly speaking, cannot be applied to the embryonic and early fetal life. So over here you can appreciate a gestational sac with a large hypoechoic area inside, that is the yolk sac, and on the yolk sac you will be able to appreciate a fetal pole, and that fetal pole can be measured. Starting from 2 mm onwards, the sensitivity of the eye is such, and so you will be able to appreciate a flicker on that fetal pole. So when in the beginning the yolk sac will be around 2 to 3 mm, when the GS is around 10 mm size, the presence of the embryo If at all it is there, we will be able to assess with the crown rump length, and FCP as such cutoff value is 4 millimeter size to appreciate the cardiac activity. If we are not able to appreciate the cardiac activity, we have to monitor that one for the early pregnancy problems like absent cardiac activity, the missed abortion. We have to have a correlation with the beta HCG estimation in the mother with the help of this pathological test. So the gestational sac, 5 weeks, the beta HCG should be around 1500 to 2000. When yolk sac appear, 6 weeks, and it will be 2500 milli international unit per ml will be the beta HCG. When fetal pole appear, it will be around 7 weeks pregnancy, and the beta HCG will go up to the 5000 milli international unit per ml. The fetal cardiac activity, when you appreciate with the help of transvaginal sonography, it will be usually 8 weeks pregnancy, and the beta HCG will go above 17,000. So over here, with the help of the sonography, you can appreciate varieties of the position of a yolk sac, fetal pole in the GS. So to differentiate that one, whether this pregnancy is a normal or a abnormal, we have to perform a transvaginal sonography. So when you perform that one, it will decrease the time of uncertainty. To differentiate from viable to non-viable, there are many criteria, and that criteria will be assessed with this one: the growth parameter, sonoembryology, and monitoring of this pregnancy when it is viable. If you put the patient on a medication, it is must to assess every week a viability of that fetus. What is intradecidual sign? That is, intradecidual gestational sac sign is identified as early as 29 to 35 days of the gestation, and there will be the double rim sign will be there, surrounded by a rim of a gestational sac and rim of a myometrial endometrial junction. Over here you can see the ring sign. That is a very tiny hypoechoic area in middle of the cavity, and that is known as a ring sign. Then over here you can appreciate the double rim sign. What is double rim sign? It will give you the differentiation from a clot or a pseudosac or a normal intrauterine GS, where you have to identify the one rim of a endometrial myometrial junction as shown over here, and then the red arrow is showing a rim of a gestational sac, that is a two rim, so it is a double rim sign, and that is a sign for a normalcy of a pregnancy. The quality of GS, over here both the GS, they are normal, but the second image is showing a one thin line inside, and that line will give you the idea regarding the poor progestational stage, and because of that LPD, luteal phase defect, this type of the line persists, third line persists. So the earliest sign of this one will be appreciated around 4 to 4.5 weeks. Implanted on one side of the uterine cavity, eccentric usually, and yolk sac appear just after 4 weeks, that is around 4.5 weeks. So the first structure usually appear in the GS, that will be the yolk sac. And so the cutoff value to appear that one, when the fetal GS will go beyond 8 millimeter to 10 millimeter, there will be the yolk sac with the help of the transvaginal sonography, and when you are performing a transabdominal sonography, it goes beyond 20 millimeter, that should be the yolk sac. But now the people are not performing the transabdominal sonography for early pregnancy problem. Echogenicity of the GS rim usually more in comparison to the myometrial. Over here the arrow has shown that one. Echogenic ring with the anechoic center within the uterus can be appreciated. Fluid filled sac surrounded by the echogenic chorionic decidual complex can be appreciated, and less diagnostic value in embryonic demise as it continue to grow. Because of that thing, people are not paying a much importance to the development of a GS when the embryo and yolk sac is not there. So the mean sac diameter The importance of the mean sac diameter, when there is a normal GS is there, we have to measure the 3 diameter. Over here it has been already shown. In the cross section we will be anteroposterior and transverse diameter, and in longitudinal sections we have to measure the longitudinal length of the GS, and it will give you the mean sac diameter, and normogram is available for the assessment of a gestational sac. Now over here we will be coming to discuss regarding the yolk sac sign. So what is the yolk sac? Yolk sac is the first structures in the GS which will provide the nutrition to the embryo, and because of that thing the yolk sac comes first instead of the fetal pole. So the preparation will be going for the nutrition, and so the yolk sac, when it is normal, there will be the normal outcome in that one. So the normal yolk sac, normal outcome, abnormal yolk sac, abnormal outcome. Over here what we have shown you, that cardiac activity with a fetal pole on the yolk sac, you can see that one, and because you will be able to appreciate that one. So the double bleb sign, what is double bleb sign and what is signet ring sign? So the signet ring sign is a presence of a embryo on the yolk sac, and see the relation of a yolk sac and the fetal pole. You will be appreciating a first image, that is the signet sign. And there is a double bleb sign. That is, what is double bleb? 2 bleb. One is the first structure, that is the yolk sac bleb, and the second structure, when embryo is there, embryo is covered by the amniotic cavity, and that becomes the double bleb sign. And the importance of the yolk sac, that we have in previous slide we have said that it is the preparation for the nutrition of that one, and so the guide to seek the embryo and size not useful in determining the gestational age. But when the normal yolk sac, first structure, it will be around 2 to 3 millimeter, and per day the yolk sac will be growing at a rate of 0.1 millimeter and will be reaching to the 6 millimeter. When it goes beyond 6 millimeter, possibility of the problematic pregnancy will be there in that condition. When there will be the unusual other problem with the yolk sac, there will be the chance to have a poor outcome in that pregnancy. Over here again there will be the fuse image of double bleb sign. So double bleb sign you can appreciate in the first image, that is yolk sac is normal, but the amnion with a fetal pole, there is no correlation of a amnion and a CRL. Usually amniotic cavity diameter and CRL will be equal, but over here in the first image there is no correlation of that diameter and CRL. Another sign, earliest is the double bleb, and in the early stage there is no correlation of that one. And second picture, a third picture, you can appreciate that one of a twins pregnancy, 2 yolk sac, 2 fetal pole can be appreciated in that one condition. So yolk sac, fetal pole and amnion, over here we have completed that one. And now coming to the differentiation from the double bleb sign from a twins pregnancy, that is the monochorionic twins pregnancy. Many a time you will be appreciate over here that is a 2 yolk sac like a structure, but it is not 2 yolk sac. It is 1 yolk sac, and with fetal pole it is covered by the amnion. While over in the third image, that is the definite 2 yolk sac and 2 fetal pole. So it become a monochorionic twins pregnancy, and we have to follow this pregnancy properly. Regarding the sonoembryology, over here few words, that less than 9 weeks conceptus is known as a embryo. More than 9 weeks conceptus is known as a fetus. Implantation site, that is the chorion frondosum. Later on, after 10 weeks, it will become the placenta. Other site regress. Usually what happen in the early stage of the pregnancy, there will be the proliferation of a chorionic activity all around the GS. Over here in the image you can appreciate the breadth of the chorion frondosum all over, it will be equal, but later on when it grows more than 9 to 10 weeks of the pregnancy, there will be the chance to have a regression at the other stage. So you must have learned in your early stage of embryology that how the GS and the lacunae and this chorion frondosome develops. You can appreciate over here red structures, that is the all maternal sinuses open up, and there will be the trophoblastic vessels invaded to the maternal spiral vessel, and it forms a very good vascularity for the feeding of this embryo. And with the help of the transvaginal sonography over here, you can appreciate that lacunae, that is the hypoechoic area in the chorion frondosome, and that lacunae will be not a problematic things or a abnormal things, but it is a normal development. Many a time the novice will be appreciating this one as a hydropic degeneration. It should not happen, and one should understand what is the difference between the lacunae and the hydropic degeneration. And regarding the chorion frondosome and development of a placenta, that is maternal portion is known as a decidia and fetal portion is known as a chorion. And the chorion frondosome, that is the busy chorion, arise from the polar body of the human embryo trophoblast, and it consists of a layer of the trophoblast and the embryonic mesoderm surrounded by the numerous villi, and this portion of the placenta is located at the site of the implantation. So you can, dear friends, you can appreciate over here the difference, that is the decidia basalis, that will be the implanted site, decidia parietalis, that will be the covering site, but there will not be hardly any maternal sinuses will be there. Decidia capsularis, it will be cover the embryo, and uterine cavity, that will be considered a double decidual sac sign. So the space over here, the hypoechoic space, at one side you can appreciate the GS, and at other side, contralateral opposite side, you can appreciate a hypoechoic area, that is the double decidual sac sign. That will be usually the uterine cavity is not completely occupied by the developing GS, and it happens so. And so many a time the people will be putting a wrong diagnosis, a collections of a blood there and separation of a early pregnancy. So you can, with the help of the live these clips, you can appreciate the presence of a this GS with a space, hypoechoic. Yes, over here you can see the hypoechoic space, and that will be a space in the uterine cavity and not the collections of a blood, or not a twins pregnancy, or not a unfused amnion. So there will be this type of the all differentiating point which we should give a attention during the assessment of a double decidual sac sign. What is double rim sign? To differentiate the pseudosac or to differentiate the clot inside the cavity, over here on the third image, you can see that it is a clot. There is no double rim sign. While in another two one, first and the second, there is a double rim sign. The larger arrow is showing a myometrial endometrial junction, and smaller arrow is showing a GS rim, and that will give you the idea regarding the differentiating point. Then the presence of the embryo on the yolk sac and its relation. Over here is the electron microscope is showing a relations of a yolk sac and fetal pole, and at 5.5 weeks gestational age, 2 to 4 millimeter embryo will be there, and we will be able to appreciate the cardiac activity during that period. When the embryo grows more than 7 millimeter, there should be the cardiac activity, but when it is not there, chances of having a poor outcome in that pregnancy will be there. So this is regarding the cardiac activity and problem of that one. You can go through this this one. Then regarding the how to appreciate that one. See the relations of a yolk sac and the fetal pole and the cardiac activity over here in the live image. Then another one, see with the help of, usually we should not use the Doppler or a power Doppler on the early developing embryo, but we can use the M mode to appreciate the cardiac activity, and over here you can appreciate the M mode, and the signet sign is there. Signet sign, that is the presence of a embryo on the yolk sac. Again, regarding the criteria of a fetal bradycardia, so the CRL when it is less than 5 millimeter, the heart rate when goes less than 80, chances of fetal demise will be there. 5 to 9 mm of CRL, at least heart rate should goes beyond 100, but when it is less than 100 beats, chances of bradycardia, and bradycardia is a real killer of an embryo. When embryo grows beyond 10 to 15 millimeter, it should be, the bit should be more than 110, but when it is less than 110, chances of poor outcome will be there. The relation of a embryo and a yolk sac we have discussed regarding this one. So over here, the focal area of a echos, that is the eccentric presence of a yolk sac in the GS, you can appreciate over here. The red is a yolk sac and green is a embryo. That is the relation of that one. And the FCP will start as soon as you will be able to see the fetal pole on the yolk sac. So when the CRL, usually the embryo will be growing at a rate of 1 to 2 millimeter, when it will be around 5 to 6 weeks of the gestation. CRL increase per day by 1 millimeter, and rule of thumb for the CRL is 7 millimeter at 7 weeks. Thereafter 1 millimeter per day up to the 10 weeks of the pregnancy it will be growing. So we have to keep these all things in the mind when you assess these all things with the normogram, and those who are clinician, just by observing the embryo you will be having a appreciations just by keeping this thing in your mind. Then regarding the few words regarding the embryo, that is seen as subtle area of focal thickening along the periphery of the yolk sac, that is the signet appearance. Should be generally noted when the mean sac diameter grows beyond 18 millimeter, that is the cutoff value with the usually we should follow for particularly diagnosis of a missed abortion or a non-viable pregnancy. Threshold for embryo detection is when the embryonic disc measure around 1 to 2 millimeter. The presence of the cardiac activity almost seen when the embryo is seen and can't wait until the embryo grows up to the 7 millimeter. And always measure the cardiac crown rump length when it is seen, and not the GS and not the yolk sac and these all things. So importance of the crown rump length assessment, it should be measured in longitudinal greatest measurement and omit the limbs and the yolk sac. Measure for the top of the head to the rump. Then the measure between the 7 to 13 weeks in neutral position. There should not be the hyperflex or a hyperextension of a neck. Accurate variability will be 3 to 4 days of a LMP will be there. So the accuracy of assessing the gestational will be best during the early stage. And we have not to change this corrected date when we have assessed that one in the early pregnancy in later on condition of a pregnancy. So this will be the just explanation of how to assess the crown rump length. Crown to rump, it is said over here, you can see the C and the R. We have not to include the limbs and the yolk sac in that condition. So you can appreciate these all are the image will give you the idea regarding how to measure the crown rump length. Then again another image that is for the measurement of the crown rump length, and see this is the live embryo. You can appreciate that one when it goes beyond 10, then it will become, we can say that one as a fetus. Then over here with the comparison between the transabdominal sonography, first image is a transvaginal appreciation and second image is a transabdominal. You can see the difference, see the magnifications. You can able to appreciate in the first image a amnion covering the fetal pole, while over here in the transabdominal sonography, because of the full bladder, we are able to see these all things, but the detailing of the pregnancy we may not be appreciate like a transvaginal sonography. Even there is a difference in the measurement, little difference also you can appreciate. So always utilize up to the 12 weeks of the pregnancy a with the help of the transvaginal sonography. So transvaginal sonography appreciation when the uterus goes beyond the pelvis, we may not be able to use the transvaginal sonography. So 13 weeks or 12 weeks of the pregnancy, the uterus will be coming out of the pelvis, and there will be the better appreciation with the trans-abdominal sonography. And so the anti-assessment, nipple translucency assessment and other criteria to assess the down baby, that all will be assessed with the help of the trans-abdominal sonography and not with the transvaginal sonography. Gestational age assessment will be proper if you assess that one earliest, but mean sac diameter is not that much reliable. Once you are able to appreciate the embryo measurement, that is the CRL measurement, will give you the final answer. So we have to follow that criteria, and there is a correlation between the CRL and menstrual age assessment, and normograms is available, and we have to follow this one for the assessment. But there is a software inbuilt in the sonography unit, and because of that thing, we have not to keep these all things ready at our clinic, because as soon as you measure the embryo, the appreciations of its gestational age will be there by the software. So the sonographic landmark over here, you can appreciate in this image that gestational sac, if you measure, there will be the 5 earliest, there will be the, with the help of the transvaginal sonography, it will be 4 to 5 weeks, and with the transabdominal sonography over here, you can appreciate after 1 week late. So the appreciations of presence of these all early development will be 1 week late in comparison to the transvaginal sonography. Even yolk sac, you can say over here, that is 1 week late. Over here fetal pole also will be 1 week late, and cardiac activity also will be 1 week late. So transvaginal appreciation will be better. Appearance of a early pregnancy structure, that is, you can appreciate over here the gestational sac 100% seen with the help of the transvaginal sonography around 28 to 35 days. Later on, we does not require to assess because yolk sac will be there, and normalcy of the yolk sac assessment is a proper thing with the transvaginal sonography. Once there will be the embryo appreciation, you can see around 42 to 49 days, 86% of the patient will be having a proper assessment, and cardiac activity, heart activity will be appreciated, that one during 42 to 49 days in 86% of the cases, while 100% you can be appreciate around 50th day of that pregnancy. So regarding the terminology used in these all things, that is what is viable. That is a pregnancy is viable if it can potentially result into the live bone. But non-viable is what? A pregnancy is non-viable if it cannot possible result in a live baby. And ectopic pregnancy and failed intrauterine pregnancy are non-viable pregnancy. And intrauterine pregnancy of uncertain viability, that is, a woman is considered to have an intrauterine pregnancy of uncertain viability if transvaginal sonography shows an intrauterine gestation with no embryonic cardiac activity and no findings of a definite pregnancy failure can be appreciated. Pregnancy of unknown location. A woman is considered to have a pregnancy of unknown location if she has a positive urine or a serum pregnancy test and no intrauterine or a ectopic pregnancy is seen on transvaginal sonography. Then regarding the common pitfalls in the assessment, that is the LMP is unreliable in almost 50% of the women. Irregular cycle will be there, just stop oral contraception, and lactating lady, these all are the 3 conditions where the LMP is not reliable. Visualize of all of the uterus, usually when there will be the pathology, suppose there will be the myoma is there, we will be facing the problem in that condition. Diligently scan the adnexa, Because in the adnexa, many a time there will be the problem, adnexal mass will be there, many a time cyst will be there. That also will be having a problem in assessment. Subchorionic bleed are not additional gestational sac. That we have to keep that one in our mind, and that we have discussed in past slide. Extreme caution about the pseudo sac should be taken, because that should not monitor that one. There should be the yolk sac, there should be the presence of viability also should be there, and beware of the fibroid. So the take home message is what? The transvaginal sonography has opened up many new avenues in the field of early pregnancy problems. First is the sonoembryology. TVS is superior to the transabdominal sonography in assessing the early pregnancy. Dilemma of 50% intact pregnancy with a bleeding PV will gone if you assess with the transvaginal sonography. In the era of TVS, early pregnancy loss marker should be assessed with the transvaginal sonography. Relying on the prognostic marker of early pregnancy, monitoring with the medication is most wanted things for the better outcome of a early pregnancy. Thank you very much for patiently hearing.